This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I interview Dr. Stuart McGill to understand the McGill Approach. We discussed different mechanisms of back pain, the most common causes and cases, treatment strategies, and Dr. McGill's opinion on press-ups. Dr. McGill is Professor Emeritus after 32 years at the University of Waterloo, Canada, who authored over 240 scientific journal papers and 4 books. His work and research probed back injury and pain mechanisms, rehabilitation approaches, and performance training. If this sounds interesting to you, please consider subscribing to our channel, hit the notification bell for updates, give us a thumbs up, and share with fellow clinicians you feel might benefit from this conversation. Thank you for listening, and we hope you enjoyed the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Fitter First, your first choice for the best Canadian-made rehab and fitness products since 1985.
Systems for PT, the Do Anything, Anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Hi Stuart, welcome to PT Pro Talk. How are you today?
I'm fabulous. Good morning, Mariana. I understand you're in Nashville and I'm in Ravenhurst, Ontario, Canada. Winter's starting, so I've got a little bit of scruff going here for the winter beard, so I apologize for my appearance today.
You gotta do what you gotta do, adapt to the cold weather. Okay, so let's start talking a little bit about yourself and your career. For the ones that don't know, you just give us a quick overview.
Well, I was a professor of spine biomechanics for about 30 years, just over 30 years at the University of Waterloo. And we tried to create what I call the 6 pillars of evidence, probing and investigating low back pain, rehab, performance training, and that sort of thing. So the first laboratory was equipped to measure the mechanical things like 3-dimensional spine motion, muscle activation through EMG. And then we created computer models of the individual. So we would take their MRI or CT scans, serially stack the images, create their virtual spine. So as they moved in the laboratory, their virtual spine moved. And we could create stress maps on deformations in the passive tissues like the discs, the facet joints, ligaments, and that sort of thing. And then we put on the forces and stiffnesses from the motor control strategy that they used and distributed them appropriately. And it was so interesting that the areas of highest stress were almost always the areas of pain. Not always, but almost always. And then we measured things like spine stability and how people strategize to create or failure to create some of these support conditions to do things with their back. The second laboratory I created after that was designed to now apply these stresses. So we took cadaver spines and we put very specific loading protocols to them, like specific repeated movements and under specific loads, and we saw what happened, what breaks. How do you create a herniated disc or a fractured pars or a spondylolisthesis or whatever. And then the third pillar was we then created the experimental research clinic, where I started off setting aside 2 hours to assess a back pain person coming in. And my medical colleague said, 2 hours? What are you going to do for 2 hours? And do you know, Mariana, after the first year, we moved it to 3 hours. And that's how, but that included an assessment and then a summary of what their pain pathway was. And then we would give an opinion of what to do and not do and demonstrate coaching of specific strategies. Then the next pillar was epidemiological studies, and you know how different pain patterns cluster around different sports and different occupations. Why is that? So we would examine the clusters and then the similarities of conditions that led to these specific types of pain. We did some clinical trials to see on specific groups now, do specific interventions help? And I guess the sixth one that I forgot earlier was in the laboratory where we did damage to spines. We also had a radiology suite that we created. So we could get a one-to-one match now between what we were seeing on radiological images and the alleged mechanical insult that led to those things. So they were very informative, but it was those 6 pillars that we put together to get opinions on these various issues. And I retired 7 years ago from the university, and now I just see patients 1 or 2 days a week, and we select them. They have to travel a long distance to get here. So they're very special patients and very committed, which is different than the regular population that you would get, say, at a university clinic or a private clinic.
Great, and I believe it's probably wonderful to work with them because they really want to get better and are trying everything. So they will do everything you say, I believe.
Not always, you'd be surprised, but I get much better compliance now when a person has to make effort to get here. They pay money, etc. So they've got a lot of skin in the game versus, say, an insurance company was paying for them to go to the university.
Yeah. And with all these pillars that you just mentioned, so I believe you found out a lot of different mechanisms of back pain, right? Would you talk about those mechanisms?
Yes. Let me begin that line of logic at the highest level. And you've probably heard this before, that back pain, you could say genetics and personal characteristics loads the gun. Exposure to specific stressors pulls the trigger. And once that pain or injury or discomfort has begun, now the psychosocial milieu for that person affects how they handle that pain or disability or however it's manifested. So that's at the highest level. That philosophically is at the level of non-specific low back pain. Now, that does not exist in our world. We try and perform a comprehensive assessment so that they don't have non-specific back pain. They have very specific pain pathways. Do you want me to discuss some examples of specific pain pathways, or I think you said mechanisms of pain now?
Yes.
Okay. So let me just start off with a knee example. You can imagine if you have a knee, a normal knee rotates with a center of rotation that's inside the joint. If you damage a ACL or some ligamentous controlling structure of the knee rotates, but it also has a clunk in shear. As you decrease the rotation and experience shear, that is an instability. So the joint has lost controlling stiffness, and the body uses stiffness to control motion, both at a joint level and at a macro linkage level as well. So if I may, I'll just use one of my favorite models here from Dynamic Disc Designs. So I've just explained an unstable knee, and you would do a drawer test on the knee to determine whether that is mechanically unstable, and B, is it causing pain? So consider a spine from exactly the same philosophical perspective. This joint is normal, L3, L5 is normal, but L4 has been damaged. It has now lost some stiffness and therefore is unstable. And it looks like this. I'm just going to apply a general torque, and you see how the majority of the motion is now at the joint that's lost stiffness. That joint is unstable. And when we then measure the stress concentrations and the work being done by the facet joints at that level, not at the normal level above and below, you now start to see why those facet joints, after a couple of years, they will start to become overworked, arthritic, they grow thicker, they may create an impingement on the lateral foramen nerve root only at that level. We might, anyway, so once a joint has become unstable and manifesting this behavior, we would then say, all right, well, you've got pathological movement at that joint. Now we would figure out, well, let's do a compressive test. Oh, compression doesn't trigger pain. Let's do a prone shear instability test in the sagittal plane. Oh, yeah, that triggers the pain. It goes right exactly to the right. What you thought was piriformis is no longer. It is exactly a trigger. Or we might do something from the McKenzie world, like a lateral shear probe. And they'll say, oh, that may or may not cause pain, but we're starting to hone in on some very specific pain mechanisms. And then we might say, okay, well, let's do a Palloff press, because I see that's what your physio gave you to do. And then they'll say, oh, well, that triggers my pain. Well, no wonder. We just did a probe and a lateral shear on your spine triggers your pain. So what you were given was designed to cause your pain. It wasn't designed to remove your specific pain mechanism. Let's take that out and do a side plank, which is a 3-point bend on the spine rather than a cantilever creating shear. There's no shear with a 3-point bend. And then all of a sudden they say, oh, yeah, the side plank is an exercise that not only makes me feel good while I'm doing it, but it gives me about an hour of relief afterwards as well. So now we go into, well, what's the mechanism of that? And the brain remembers and keeps a certain turgidness in the torso, but it also reminds the brain of that motor pattern that arrested that micro movement. So there might be an example from instability, but then we have to backtrack a little bit and say, why had the joint lost stiffness? Well, maybe there's a disc bulge. And depending, I could name probably 20 subcategories of disc bulges, all that have different triggers and therefore very specific differences in management and treatment philosophies, shall we say. So I can keep cutting this to pain that's directional, but that's far too simple in our world. We want to get right down to the specific mechanisms so we can be very precise and say, that pain that you feel in your right toe and numbness, it's not a nerve root compression from a disc bulge. It's actually a friction. The nerve is moving and being frictioned, and that's why you only experience it on the first cycle of motion. So if you pull a nerve root cranially, for example, oh yeah, there's my pain, do it again. Oh no, it's gone. Now they have to pull a leg and say flex the hip, migrate the nerve through the friction area, and they say, oh yeah, there's my pain, do it again, it's gone. So again, these are the very extensive mechanical tests we do, but then we might have a pained person. I hate calling them patients, but anyway, that slips out of my mouth every now and then. You have a pained person, and I might just run my hand down their back to feel there might be an antalgic joint or something like that. And I just touch them and they go, ooh. I've just identified something emotional, and we've triggered that. So now that takes us into a whole different world. What's your pain? Oh, it's a 10 out of 10. Really? Could you walk around the clinic here for us? And they walk around, very joyful. And I said, really, your pain is a 10 out of 10. And I said, 9 out of 10, you've been shot and you're just about to die. Let's get calibrated here. So maybe they've been abused. Maybe they have, the stories I could tell you. One fella flew here with back pain. He says, I've got terrible back pain. And I said, okay, well, let's take your shirt off. And he had a great big infected zit on his back. And I touched that. And he goes, oh, yeah, that's my pain. And I said, well, you've come here for a zit. Anyway, I can go on and on and on. Trainers who create pain in patients by not understanding they are the masters of tissue adaptation. Their programming in a personal training session is designed to stimulate an adaptation in their client to become more robust for life. But what's the client-trainer relationship? Oh, my trainer is great. He made me sore today, or she made me sore today. Wait a second. That's not what it's about. It's about training you to be more robust for life. And they sometimes don't get the balance between what is required for specific adaptation stimulus. Then you need rest. If they did a deadlift of their body weight, don't do that again in 3 days. That's an adaptation mechanism that takes close to a week in some people, depending on where they are in their bone robustness. Anyway, I can go on and on for hours, so I'll be quiet. But there's just a little bit of a beginning in the world of pain pathways and mechanisms, I think you called them. Sorry,
Yes, and
a bit too long.
No, it's fine. You explained very truly. I was gonna ask on the stability one that you mentioned. So it's mainly caused by like disc bulges, the instability. Is that the main cause?
No, it's caused by any structure that has been compromised and now allows a shear movement. So the normal rotation is disrupted. And I showed you in that particular example, the person rotates and creates all kinds of stress concentrations. Now that might be an end plate fracture and a loss of pressure in the nucleus. So consider a car tire where you let a little air out of the car tire. Yes, you get a bit of a disc bulge of the car tire on the road, but now the car is sloppy on the road. It's hard to control. So in that particular example, we might find a muscle stiffening strategy that controls out that micro movement and takes their pain away. One of the last studies I did at the university was on whiplash people, and I partnered up with one of my PhD students and a doc named John Baird near Toronto, and he had a video fluoroscopy machine, and he's very well known as being an expert witness in lingering whiplash. Typically, a person is 2 years post-motor vehicle accident, and the attending docs will say, oh, well, 2 years, your tissues should have healed after 2 years, and your MRI isn't showing any pain mechanism. You are a pain magnifier. And now their pension and their compensation and everything is being questioned. And worse than that, you can imagine the psychological disturbances for that poor person being told the pain is in their head when they clearly know it's in their neck. So with our team of my grad student, Christian Balkovec and John Baird, we would take these whiplash patients with no real MRI evidence, because an MRI is a static picture, but we would watch them go through the range of motion with their neck. And the joints would rotate normally, but halfway through the motion, they'd go, ugh, clunk. So then we said, all right, can we come up with a pattern to make up for the lost stiffness, which that's what the injury was? Just touch yourself under here, Mariana, and you will feel the soft muscularity of the anterior neck. Now touch your teeth lightly together and push your tongue hard to the roof of the mouth behind the front teeth. You felt all the deep flexors become active. Now this is kind of ugly, but it's fun. Grimace down with your face like that. Now do it. Now keep that and rotate your neck through the range of motion. And that would be an example of a strategy that we might give to the whiplashed neck. The idea being to arrest the micro movement clunk and shear. And you'd be surprised at the number of them who've said, oh, my neck didn't clunk. I didn't get the pain. So there is, again, a technique that's very helpful for that specific type of mechanism. It takes away all the psychological concerns and wondering, am I mentally unstable and manufacturing and magnifying pain? That's a very difficult thing for some people to live with. No, it isn't. It's actually the medical system failed to pick up the specificity because the tools they were using were insensitive. So we come up with a sensitive technique, prove, and then we measure and show the courtroom graphically, or the compensation board, whoever it was. You see exactly here at the point of pain, the rotation stopped and the shear clunk occurred. That is the mechanism of their pain. They're not faking it. And anyway, there might be an example.
And then, so if you find that the joint is unstable, usually you do strengthening to try to stabilize the joint?
No, that's far too crude. No, the strengthening might make it worse.
So yeah. How do you identify which?
Well, I get it. We begin with testing different motor strategies. So say we have a lumbar clunk. May I stand up and move? Can
yes.
You still hear me all right?
Yes.
So say the person has a clunk when they rotate around and then they get a clunk just at the top, for example. I might say, all right, take your fingers lateral to your navel, past the rectus abdominis and the linea, is that semilunaris, I think? Get into the obliques. Now poke your fingers in hard. Now push your fingers out laterally. Good. Now repeat the offense. And they might say, oh, my pain is gone. So now we've converged on a bracing pattern, because when a muscle contracts, it creates force, but it also creates stiffness. So now you've created a girdled pattern that arrests their pain. But what happens when the opposite occurs? The person says, I brace, oh no, that causes me more pain. All right. They don't have the compression tolerance to support that particular strategy. So we go somewhere else. I might say, all right, pretend you're hitchhiking, externally rotate. Now, use your pecs and your lats and pull down with your shoulders. And now I say just, oh, that didn't trigger my pain. So it's a convergence search on a strategy to create a pattern that arrests their particular pain. So now it's a matter of patterning it. After a while, the pattern will probably be strengthened. And now we look at, well, what is their world? Are they a football player? Are they a swimmer? Are they a young mother with 2 kids under 3 years of age? Whatever their demands are in their particular life, we coach them, if we can, to meet the demand of their life, which is specific. So that's a whole nother level of analysis. So now we create a capacity, a pain-free capacity to meet their particular demand. It's not a matter of, it might be a bit of strengthening. We know that the construct of that muscular pattern that works for them, in neuroscience, it's called an engram. So it's a movement tape, so to speak. We have various coaching cues to strengthen that default pattern in their cortex or their spinal cord, wherever the pattern lives. But we do know that strength training with specific coaching technique, and we did a nice study on the Pensacola firefighters actually to prove what coaching styles create transference from the clinic to real life. But we use all of this information to create that default engram and then strengthen it.
Okay, so just for the ones that are listening to us, you can watch on YouTube and see he's demonstrating all the movements and everything, so you can go there and check it out.
Yeah, sorry, it's the only way I know how to teach, Mary. I could never, as a professor, stand behind a podium and teach. The students were jumping down off their desks.
That's fine. It's easier to understand that way. So let me see if I got it right. So you start with kind of like a muscle activation to try to see which way it helps that joint to like have a better motor control. And then from there, you create a strategy that might involve strengthening. But first, you are trying to activate certain muscles to see if the joint can tolerate that pressure or that force.
Usually, but not always. Sometimes the person is overstiff and they come in, walking like a robot, and they are overstiffened. So I now have to go through a relaxation pathway to address their pain. So you see, I know that there's so much mythology. People will show me, oh, this guy said, on the internet, he did the big three and he got worse. Well, okay, we wouldn't do the big three either. We would assess the specific mechanism, and it may be with that person. Here's how we're going to start with you. Would you lay on your tummy, please? And then we've identified, yes, they have a maladaptive motor response. It's way overstiffened. Whoever was coaching them wasn't a good coach. They just said, oh, pretend you're going to be punched in the stomach, and that's how you should walk around. Oh, it's awful. And then I might say, what is the mechanism upstream that's causing you to react this way? Okay, well, you've got a open fissured disc bulge, but the upstream mechanism was a posterior fissured disc bulge. So let's try and decompress that. And I would say, lay on your tummy, relax, breathe in, and as you exhale, surrender. Let all the grip, let the grip in your gluteals go, let the grip in your low back go. Inhale again, let it go. Are you getting better or are you getting worse? And they might say, I'm getting relief. Good. So also strengthening, it's the polar opposite. So I'm not trying to avoid the question. Actually, the polar opposite. I'm trying to give a comprehensive answer and understanding. It always depends, and the assessment always shows you the way.
Yes. So what would you say is the most common mechanism of pain that you identify, like through your career and all the patients that you see?
Dysfunction of the disc is usually the beginning of most people's issues. So this allows aches and pains at the joint as the pressure is lost in the nucleus. The joint loses a tiny bit of height. That over time adds more load and different loads to the facet joints. It compromises nerve roots. It triggers off all kinds of neural responses with the shear displacements. A person might say, oh, I lay on my left side, I'm fine. I lay on my right side at night and I get this ache in my low back. And I'll say, all right, we'll put a little pillow under your waist on your right side. Oh yeah, that took my pain away. So again, these are all at the very root or core of them are disc changes, shall we say. So I would say that's the most common. And then as a person gets older, it shifts away from the disc to more, I don't want to use the word arthritic conditions, but the spine naturally stiffens. And we will see friction on nerve roots from central stenosis, foraminal stenosis, just plain old deconditioning. But maybe, the rotator cuffs are severely compromised in their shoulders, their knees have been replaced. And, it's a different picture. So there's my answer for typically most of the people we see being younger. And then after the age of 60 or so, it really shifts.
Okay. So with those that you find that they have a dysfunction of the disc, what are the strategies that you use to treat them?
The strategy matches what the assessment shows is their specific pain mechanism.
And that would be like a specific direction. I remember that I saw one of your interviews, you were talking about the ones that are flexion intolerant and extension intolerant, and their probabilities of having a good outcome. Is that related to the disc? So when do you test their movements, and how do you know if they're going to have a good response? I remember you said something about the flexion intolerance with compression intolerance are the ones that have, I think, the worst outcome.
Yeah. Okay. I get your question now. So our experimental research clinic, we started that, I can't remember the year, but it was about 20 years ago. And it was quite unique in that I said, we're going to follow up with every patient we ever see. We're going to keep our score and we're going to know. So when a person came in, we would subcategorize their pain mechanism. We would record what we told them to do. And then within 2 years, we would perform follow-up and ask, how are you doing? Did you comply? And some of these normal follow-up questions. I don't know of another clinic that's done that for every patient that they've ever seen. So I think that's what you're talking about. And we cut the analysis quite finely. So now remember, at the university, we would get opioid addicts, people hooked on various pain meds, the real full spectrum. And they were very difficult patients in that they've already failed usual approaches. They've been to the physio, the chiro, they've had a surgical consult, they've probably been to the pain clinic, that's where they got the meds from, etc. So of all of those people, if they have compression intolerance, by definition, they will have flexion intolerance because flexion causes more compression. So that was the most difficult category. So I can just look it up on my table here. After 2 years, and remember, it was only a 3-hour consult. There was no extra or anything else. 33% of them said they were cured with no issue. But that also means 66% of them were not. So that's the most difficult category by far. If they were motion intolerant, in other words, pain into flexion and pain into extension triggered their pain, the number dramatically changed. 80% of them after 2 years said, I'm fine. So we showed them how to avoid that pain trigger, wind down their sensitivity, and here's a progressive plan to come along. If we go by tissue, let's say they were truly discogenic in the genesis of their pain. 47% of them said, I'm fine after 2 years. And remember, these people were shooting zero. They tried all these other things first. If they were disc plus facet, so further down the cascade now of pain and change, 78% of them said they were better. But here's the statistic. If they fell into the category of you've tried everything and someone has told you now that you need surgery. So if you're in the category of you need surgery, 95% of them said they avoided surgery and they were glad that they did on follow-up. So that's a pretty good statistic. Now we post-hoc analyzed all of the data that came from that particular follow-up. Then we would look at tests. What tests were the most predictive of who would do well? So if they did the McKenzie prone and getting up on the elbow kind of test, did that trigger your pain or not? That was predictive up to 50% as to whether the person reported that they were fine or not after the 2 years. Most of the tests, we would go with a hip scour test. Are your hips involved in triggering the pain? That had about a 50% prediction on whether the person would get better or not. But the one that was the most predictive was, that shear instability test. If the person showed positive on that, in other words, the genesis of their pain is truly from shear instability, only 50% of them said they were better after 2 years and didn't need any more directed therapy, shall we say, for their back. But if they were negative, 80% of them said, I'm better. So clearly, that spine instability category, which most clinicians don't even know about. So, say you did a McKenzie prone push-up. That would really trigger off some people with some heavy joint instability. But usually they will have a disc bulge as well. So sometimes it's really effective, as you know, and sometimes it's terrible. It really kicks off a nightmare for the person. But at least this level of, the 6 pillars of evidence that I mentioned earlier really help hone the precision on this. So I had one PhD student. She was a physical therapist. Her name was Joan Scannell. Very good McKenzie-trained physical therapist. And we took cadaver spines, young cadaver spines, and she would flex under load and begin a partial disc herniation. And we dyed the nucleus with barium so we could watch the nucleus slowly create the disc bulge as it started from the inside out, breaching through the concentric layers of collagen. And that's how the vast majority of disc bulges posteriorly occur. Repeated flexing, squeezing, creating nuclear pressure, and the nucleus seeks the path through the delaminated collagen of the annulus. Then she would try and return the nucleus that had breached through the annulus, because this is the foundation of McKenzie. And I used to talk to Robin McKenzie about these kinds of things. And it was so interesting. The McKenzie Foundation never even did this work. I ended up doing more scientific investigation of the McKenzie techniques than they ever did. And yet they were pontificating about mechanism. It's like squeezing a bar of soap back in, and you needed repeated motion and the floppy push-ups and whatnot. So Joan then did repeated extensions, mimicking the prone press up, to try and get a vacuuming effect occurring to draw in the nucleus, because that's what was being proposed by the McKenzie Institute. There was a very specific statistical breakpoint, and it was the height of the disc. In other words, if the height of the disc was 70% of its normal height or more, the prone press-up helped vacuum in the disc bulge. If the disc had lost more height than 70%, it was squashed down a bit, the McKenzie prone press-up tended to not vacuum in the disc bulge. So there was the first level of precision that we discovered. Then in another study, I took some spines and we did the same thing. We created partial disc herniations, and then we didn't do prone press-ups. We simply adopted a McKenzie isometric position, not movement, just extend and lay. Do you know, Mariana, we got exactly the same vacuuming effect of the disc if the disc had 70% of its joint height remaining or more. So if it didn't work in squash down discs. So this was a concern raised, because now I go to the clinical pillar. It was when we would monitor the patients coming in and we said, what have you been doing? And they said, well, I did have a disc bulge and I went to a McKenzie practitioner and we did prone press-ups. Oh, well, how many prone press-ups did you do? Oh, well, it worked pretty well for a week, but I've kept doing them. I've been doing them for a year because the therapist told me to do them every day. So many. Now you have arthritic facet joints. So the disc had lost some height. More load automatically goes to the facet joints, and now every day they irritated their facet joints by moving them. And the more the joint instability, the more the trauma to the facet joints. So this was the concern. So where do we stand now? I'm really not a fan of prone press-ups. They unnecessarily load and friction the facet joints. Instead, just adopt the isometric McKenzie posture, and we could do all kinds of sub-treatments on that. Lay prone and then breathe, relax, allow a normal lordosis to work its way into the low back. That in of itself is vacuuming of the disc. Sometimes a little bit of 5 pounds of traction, or 2 or 3 kilos for the rest of the world, traction from the therapist while they're in that position helps accelerate the vacuuming in process. Sometimes that hurts. If there's too much instability, that triggers their pain, and the patient says, oh, no, this is worse, please stop. Or they say, wow, that's even better. Keep doing it, therapist, please. And then we would say, okay, let's add a little bit of motion, because we suspected now with the prone press-up, does the motion, as Joan wanted to investigate, add to this vacuuming effect? But as I said, the trauma to the facet joints after 2 years was, or even sooner, was a bit of a concern. So we would take the feet and watch my hands. I'm holding the ankle joints now, pulling it with a little bit of traction. Do you see how that's a windshield wiper motion? And then I watch the pelvis just slightly roll and float like this. That accelerates the vacuuming process under a mild traction in some people. The next person, it makes them feel sick. Why? They've got micro movements triggering their pain as well. So we got a lot of insight as to why in some patients the prone press-up and a McKenzie approach is magical. It's the right thing to do for a week, no longer. And after that, there may be isometric forms with nuances, as I've described, but the precision on this will get you a much higher efficacy rate.
Very interesting.
I would meet Robin McKenzie at the ISLS meeting, International Society for Study of the Lumbar Spine. We were both members of that. And he was a lovely fella. Just wonderful to talk to. And he had invited me to come down to New Zealand. And then he had a stroke, as you know, and passed on after I can't remember how many years after that. So it never came to pass, but I would have loved that trip. Anyway, there's my little nod of the head. We all stand on the shoulders of some pretty spectacular people, and Robin was one of those.
And I have a lot of considerations. So you feel like with everything that you said, end range would be good for some people in the beginning of their treatment, but then would not be necessary to vacuum the disc per se. Like you said, that just the prone on elbows had the same result if they had a 70% or more of their disc height. Is that right?
No. You said prone on the elbows. Maybe it's just simply two hands stacked under their chin.
So just lying prone.
Yeah, maybe it's just resting their cheekbone on the table. Maybe they're laying prone with their cheekbone on the table and they say, I've got a little ache in my back. Push 1 kilo of your cheekbone down into the table. Oh, that took my pain away. We just arrested and supplied stiffness that now allowed a McKenzie treatment to be tolerable. Failure to do that, the McKenzie was poison. So no, you're backing me into it's just this, then it's just that, and I cannot go there. The precision on this and the efficacy rates, it's a skill.
That's so complex.
No, it's not complex. We teach an approach that leads the patient and the clinician away from their pain. And it is a series of steps. But if you do your thorough assessment, and that's what we teach, the therapist will converge on what takes the person's pain away and addresses the deficit so they can now build a foundation, hopefully working through to pain-free activity.
Okay.
Yeah, no, you can't box me in on it's just this or that. It never is.
I know. It's just trying to understand here the rationale, but I understand that's more to that. And when you said that the disc was 70% or less, that it's harder for them to respond, so they tend to not respond to the extension, for example. So what would you do on those patients? Is there like a different approach or a different route that you go through?
Yeah, of course. Yeah, teach them how to move that doesn't trigger their pain. That's the short answer. The long answer is if we had a person in front of it, I would show you how we would converge on a strategy for them. I can, one study I did with one of my Brazilian students, we measured people slouching in a chair, and then we watched how we said, now sit upright. Okay, I'm just going to turn my camera down so if people are watching this on YouTube, they'll get what I am doing here. Maybe something like that. So if I slouch, observe, I'm going to extend. You saw one strategy there, and here's another strategy. Did you see one was a hip flexion pelvic driven strategy and the other was a thoracic extension strategy? So the person who says, oh, I've got pain in the middle of my back here. Good, slouch. Now sit upright. Oh yeah, there's my pain. Good. This time, rotate your pelvis. Oh, sir, my pain just went away. So, it's just a silly example, but it shows our efforts to keep searching for the precise mechanism will lead us to a strategy that addresses their pain, and it just unleashes them from hell, really. The psychosocial makeup of the person, their constitution for sleeping gets better. This is such, people try and say, oh, well, are you mechanical? You ignore the psychosocial. I said, really? I can't even have that discussion of the dichotomy of these two. They're so wound up with one another. If you deprive a person of sleep, they are mentally challenged, emotionally challenged. I am.
Yeah.
Fortunately, I had a good night's sleep last night, so I can be half compos mentis here for you. But you can't separate any of these. It's a big continuum. Anyway, I'm way off topic now.
Just on the disc topic, I have just one more question that I heard you talking about before on like lumbar flexion that has different back and disc mechanisms in yoga and weightlifters. Would you talk about that?
If I may show you with a different model, again from Dynamic Disc Designs, weightlifters, powerlifters, people who train with heavy load tend to have posterior disc bulges from loaded flexion. Yoga practitioners, some gymnasts, people who stretch a lot and do not load their bodies heavily have a very different pattern typically of what happens. And I think that's what you're addressing here. So here is a typical disc bulge mechanism. I'm just going to pull this nerve root out of the way. I'm going to flex the spine forward and I'm going to squeeze it under compression. And I hope you see the delamination stress here as the collagen separates and the nucleus is squeezed out posteriorly. That's almost always caused in people bending forward under load, either picking their kids up off the floor or not training with good form at the gym would probably be the number one these days. Not when I started 40 years ago. It was different. But that seems to be the lifestyle of the modern office worker now. Sit at the computer for 8 or 10 hours a day and go to the gym and not pay attention to lifting form. But a person who stretches a lot adapts the stiffness and the flexibility of the disc. This is not a ball and socket joint, it's a fabric. The collagen fibers make up the weave of the fabric, and then the next concentric layer, the fibers run the other way. These fibers are type 1 collagen with a much lower percentage of some type 2 collagen, which is the elastic collagen. And there's a collagen type X that binds all these together. If you stretch over and over again, the type X collagen is compromised a little bit, and you get, and you can see this in tendons as well. And people will argue, oh, well, you can adapt a tendon, therefore you can adapt a disc. It doesn't work that way because the disc is a fabric with cross weaves, and it also has to contain a highly pressurized nuclear gel. That's a game changer. Anyway, so as the type X becomes softer to allow more mobility in the spine, when you bend forward in that motion-trained, flexibility-trained person, the softness of the annulus causes the anterior to buckle. So when they go into extension, that might cure a person who trains with strength and vacuum in their disc bulge. That's the McKenzie way. But in the yoga person, as you go into extension, it doesn't vacuum it in. It actually buckles the annulus because it's so soft now. It's been adapted for mobility. And that can encroach. So you do a McKenzie extension on that particular person under compression, and bingo, you just found their pain. It's the polar opposite of a treatment. So the moral of the story is, yes, you may be able to adapt the disc to a very limited degree, but now you have to choose what you're adapting for, because you can't have both. You can't have high load bearing ability and high mobility. You have to choose one. But most people, to live life, they want a little bit of each. So you can achieve that resilience by, when you lift, use good form. When you move, play golf, don't use a lot of force. And when I measure the great golfers in the world, they don't activate their muscles to high levels at all. In fact, if you ever took a golf club out to the driving range and really tried to hit a long ball with lots of muscle, you'll know it doesn't go very far, because the muscle activity stiffens and slows the person down. So what I'm talking about is power, force times velocity. Keep the power low to keep a healthy disc. So if there's lots of velocity, keep the force low. If there's lots of force, keep the velocity low, which means don't move the back under heavy load. Use the hips in good form. So there's some general rules, shall we say, that biologically those tissues must live under to serve the owner well over their life.
Very interesting. And there's a lot of considerations that I think we don't think a lot about that as therapists. And I think it's just very interesting, all these concepts and ideas that you're exposing. Because we try to do it all. We try to strengthening, we want flexibility, and
well, no, biology will not allow that to you. And let me give you an example. Could you have a high VO2 max and be an explosive athlete? You can't, because they're two competing physiological mechanisms. You can elevate each one a little bit, but if you really want a high VO2 max, you've just identified an endurance athlete who doesn't have the fast twitch versus the explosive athlete. You know, I've worked with some of the most explosive athletes in the world. They take the elevator. They won't take a flight of stairs, because that would change some of the fast twitch metabolism into a endurable slow twitch, and it compromises. You can't have both. So there are these, and I'll put a little plug if anyone is interested, any of your listeners and clinicians who are interested. I put on a 50-hour online explanation of all of these mechanisms. It's called the Summit course on BackFit Pro. And then after the clinician goes through the 50 hours of online training, we then get together physically for 3 days and we workshop all of what we've learned hands-on for 3 days. So it's quite a comprehensive course, but it will absolutely help with the decision process and arriving at precise understandings for that particular individual, and therefore a precision to the therapy.
Very, very interesting.
I don't love or hate any therapy or exercise or anything else. I only try and use the right tool for the right job.
Yes, and it's different for each individual, so it's not like one thing fixes all.
Well, it never has.
Yeah. And what is the website again?
It's our website, backfitpro.com, just as it sounds, backfitpro.com.
And then if people go there, they can find your course. Well,
there's two entry portals. One is for a person with back pain, and one is for clinicians who treat people with back pain. So enter the clinician site, and you will see the Summit course, if that's what your interest is, to really hone your assessment, process and skills, and then put together a treatment plan and execute. And as I said, that's what we practice for 3 days after the lecture material. I used to teach these courses live before the pandemic, and I thought, oh, there's no way I can put this on the internet. I was so arrogant. when the pandemic came, whether I'm there lecturing on the screen or lecturing live, it's better on the screen because the person can say, what the heck did he just say? I can reverse now and go over it again and say, oh, okay, I got that now. So the actual lecturing part, it's better when that's online. But the hands-on, there's no substitute. You have to be live, and we're there just having, I enjoy those days so much. I'm getting a bit old and losing my stamina to be on for those days. But boy, we have fun. And everybody comes with their skills and biases, and some are really good at some things, and others are really good at what the other person isn't, and they team up and we problem solve it. It's a wonderful way. Do you want a quick story on that? Not to prolong this. But have you heard of DNS?
No.
Dynamic neuromuscular stabilization. It's the Czechoslovakian school of the Prague School of Rehab, and the person who has developed it. He was a student of Yonda and Levitt, but his name is Pavel 𝗂𝘁. So I don't know. People are funny. They're always wanting to create these controversies on social media and whatnot. So Dr. Clayton Skaggs, who runs the Central Institute for Human Performance in St. Louis, he invited Dr. 𝗂𝘁 and myself to come to this center in Florida, and we would see 3 patients. Here's the interesting part. I never saw him assess, and he never saw me assess. It was blind. And what would the McGill approach versus the DNS approach converge on for each of these athletes? There was 3 athletes. One was a MMA fighter, no slouch. He had had a few UFC contests. The next was the second fastest woman in the world. She won the silver in sprints at the Olympics. What a beast. And then the third one was a scratch golfer, not a PGA Tour player, but a scratch club golfer. So, a combat tough athlete, a incredible speed machine, and a golfer, a mobility athlete, an elastic mobility athlete, polar opposite. So first athlete comes out, I'm taken away, and I go down to the swimming pool with a cell phone and a person to lead me there. Pavel did his assessment of the first athlete. I was blinded, had no idea. The phone rings, McGill, okay, come on up. 𝗂𝘁, he has to go down and sit at the swimming pool. And I do my assessment. This was kind of a stressful thing to do. Anyway, I never knew what his results were. So we went to this little soiree party at night. And I said to the delegates, I said, well, how did we do? And every delegate said, it was fantastic. You both took very different pathways on all 3 athletes in the assessment. But on all 3, you arrived at exactly the same place. And I thought that was so powerful to show that we all have our skills. See, Pavel, he never asks a person about their pain. He sees them for back pain, but he never asks them about their pain. Me, I say, tell me about your pain. I'm doing pattern recognition. And so very, very different approaches. And I don't understand all of what he does. I watch him work, and I have some explanations for it, but he would explain it quite differently. Anyway, there you go. It's these days on the internet, they try and make a war, and the people who actually do these things, I love working with people who have different approaches, and I learn so much. And anyway, just a fun story, I suppose, to illustrate.
Yes, I think it's just like different rationales.
There are a few different paths to Rome. They all lead to Rome.
Yes, exactly. And I think that's why it's so interesting to be open to hear other approaches, techniques, other ways of thinking and rationale. And that's why I like to bring a lot of different topics here, because we sometimes get really stuck on our ways of doing, and when you hear something different, you first is like, what? That shock. And then you start to think about it. It's like, well, that may be a good idea. Let's implement that and let's see if that works, and just be open to different things. So you're always growing and trying to do better for the patients.
Yeah, I didn't get here overnight. I've been working on this and nothing else for 40 years.
Yep. And I think that's the in-person part that you were talking about before. That's why it's so rich, this interaction, and seeing other clinicians and seeing the manual part of the assessments. And COVID showed us the technology can do incredible things. Now you record it one time, you don't have to be talking for 50 hours all the time. And that's great. And it's good for the clinicians to be able to watch. And as you said, if you don't understand, you go back. So that's all great. And then the in-person part, I think it's still very valuable to have those experiences, changing of experience. And Dr. McGill, anything else that you want to add before we wrap up?
I don't think so. I just enjoy your questions and hope I've answered them. I can say if there's any pained people watching this, I wrote a book for them called Back Mechanic. It doesn't work on everybody, but it works on about 95%. And
that's pretty good.
I've written some materials. Well, the bulk of our material is for clinicians. But that's available on BackFit Pro. And we also have our program where we have master clinicians who I've worked with personally to try and upgrade their skills. So I'm now at the point I'm very confident in sending back pain people to them, specifically non-specific back pain people, because they will make it very specific. And we also have a certified clinicians program as well that each day refers patients from the website to these various people in the world to have a different approach for those who aren't doing well with their current approach to living their best life, shall we say.
Well, Dr. McGill, I appreciate your time and sharing all your knowledge with us. I learned a lot, and I'm sure all the clinicians that are listening to us also learned a lot. So thank you so much.
My pleasure, Mariana. Enjoy your day in Nashville. Go listen to some good music. Lucky you.
Yeah. Thank you.
Okay. Bye for now.
Bye.